There are specific situations where you want to do BAT1 over lampoon. I'm going to show a case. Then for valve in valve, in my experience, depending on the type of valve, some valves are easier to cross their leaflet or they are harder.
Welcome everybody. Andrei Pop here from Alexian Brothers. Delighted to have Dr. Gennaro Giustino with us from Morristown Medical Center. Gennaro is an expert in the Batman procedure, and we would really like to hear his thoughts about this very exciting technique. So, Gennaro, thank you for being with us today.
Andrei, thank you so much for the invitation, and thank you for having me. Yeah, so we'll talk about the Batman technique, which is an emerging technique to modify the anterior mitral leaflet during transcatheter mitral valve replacement and preventing LVOT obstruction. So, as you guys know, the mechanism of LVOT obstruction during TMVR usually is due to displacement of the anterior mitral leaflet towards the septum, and that obviously creates like a narrowing in the LVOT. Certain factors have been described to be associated with increased risk, such as like a long anterior mitral leaflet, a low predicted neo-LVOT, a thick septum, and so forth. And we can predict this with cardiac computed tomography. Now, when we have this situation, usually we have two ways to approach this. One is performing septal modifications, and the other one is performing anterior mitral leaflet modification. The technique that has been the most implemented so far, that was first described for anterior mitral valve leaflet modification, was the LAMPOON technique, which originally was the retrograde classic LAMPOON, where two catheters would be inserted retrograde, snaring, then the laceration is created from base to tip. Then this evolved to become a fully transseptal procedure with the integrated base to tip lampoon, and then in this further evolved into the so-called tip to base lampoon, where essentially the flying V is positioned at the tip of the leaflet, and then by electrifying the wire and pulling back, that creates a laceration. However, a requirement for the tip to base lampoon is that the mitral valve annulus is protected. As you can imagine, as if you're pulling this, you can create damage to the mitral aortic curtain. So the Batman technique is a technique that expands on this concept, where in his first description, the Batman was actually done transapical. After transapical approach, the anterior mitral valve leaflet is traversed from the ventricle inside of the left atrium, and then over a wire, the leaflet is ballooned, and then the valve is implanted in position. This has further evolved into a transseptal iteration of the technique, where after transseptal puncture, we puncture the anterior mitral leaflet at the base with an electrified wire, 035 or 14, and after that, we balloon the leaflet to allow either complete laceration of the leaflet or intraleaflet valve implantation. We have led international registry of North America and Europe. This is now further expanded. We have close to 100 cases now, since this technique has been implemented really without like much data. Has been just like used as an extension of lampoon in operators that were already familiar with that technique. In this initial registry, where we had 42 patients, results were promising. Technical success was 100%. Overall, the technique was associated with relatively short procedural time. As you can imagine, the fact that you don't need to snare the wire, creating a flying V, and then lacerate, particularly for the base to tip version of the lampoon, is convenient, as you're using the same wire for leaflet modification and valve implantation. At that time, there was an equal split between using a 035 wire and 014 wire. I would say now, more recently, I think the tendencies use more 014 wire for traversal, like in Basilica, like in Unicorn. And then after that, after first ballooning, switch to an 035 wire. In this registry, also, there were two cases where the leaflet was cross retrograde, across the aortic valve that was called the Robin technique, where essentially going with a catheter under the base of the anterior mitral leaflet traverse and then snare the wire in the LA Transseptal. And then most of the balloons that were used were a 14 millimeters balloon, followed by implantation of the valve. Overall, the 12 fluoroscopic time was 40 minutes. So despite this was at the beginning of the experience of every center, every operator had done like 2 or 3 cases on average of Batmans, these were the original results. The technique was particularly good in patients who had valve in ring and valve in valve. The primary efficacy endpoint was defined as the composite of procedural survival, successful TMVR, and a final LVOT gradient less than 50 at the end of the at the exit of the cath lab. This was considered similar to the definition that were used in the original LAMPOON study. In the valve in MAC, there was a lower efficacy, was driven by interprocedural death. One was an valve embolization due to insufficient MAC, and the other one was due to an LV perforation. Then, in terms of safety endpoints, there were no safety endpoints at all in the valving ring group. There was one event in the valving valve that was due to a left atrial laceration due to excessive posterior transseptal, and the valving MAC was consistent with the events that I already mentioned. And then, in terms of like breaking down the type of events in this initial experience, we didn't see cardiac structural complication related to Batman. So one of the concerns is that if you're performing Batman in a patient that does not have a protected mitral aortic annulus, such as similar to what would happen with a tip-to-base LAMPOON, the balloon is creating a laceration that can propagate in an irregular direction, and therefore what can potentially propagate towards the curtain and damage the curtain. We didn't see that in the initial experience. There was actually one event in a valve in MAC patient in the later experience that we are putting together right now, but in this initial experience there were not. And the other events were considered unrelated to Batman. Was one wire perforation, and one was a valve embolization. The other one was a left atrial laceration. So I just wanted to give an overview with this, and now I want to share a case.
So as you're loading that, when do you choose these days between Batman, LAMPOON, alcohol septal ablation?
Yeah, so my approach is as follows. If the patient has unprotected mitral annulus, I like to do antegrade base to tip LAMPOON. So that includes valve in max and incomplete rings. For complete rings, I like Batman. Is very practical. There are specific situations where you want to do Batman over LAMPOON. I'm going to show a case. And then for valve in valve, in my experience, depending on the type of valve, some valves are easier to cross their leaflet, or they are harder. Valve in valve, probably the easiest to do tip to base LAMPOON, because the leaflets you don't need to traverse a leaflet, so you can just like go around with the wire snare and position a flying V to the level of the leaflet and create a laceration. And so I'm kind of like still like 50-50 for valve in valves. But for the rest, that's my decision making. And then for a septal modification, unfortunately, I don't know how to do sesame, so the only thing I do is a septal ablation. So in those cases, I try to do septal ablation whenever I have, or I have really something space to gain, like you have a thick septum. Otherwise, I don't even bother.
Do you think there's any role for the meravectam and hokum drugs in these patients, or not really? You think you need to get a mechanical modification rather than pharmacological?
I think you need mechanical modification, personally.
Yeah, I agree. Yeah, go ahead. Let's see the case. I'm really excited.
Yeah, so this case was actually published today. It's a case of Transseptal Batman for a redo valve in MAC, where the neo-LVOT was near 0 and there was commissural misalignment. So this was a 78-year-old female that had 9 years ago surgical transatrial 26 millimeter S3 in MAC and a SAVR with a 19 Magna ease. At that time, when she had the surgery intra-op, it was reported that she had a gradient of 40 millimeter mercury between the LV and the aorta. Anyway, she presents with progressive dyspnea on exertion, and then was found to have severe bioprosthetic MS of the S3 implanted in the MAC position. She was deemed a prohibitive surgical risk. So this was the CT, the preoperative CT. You can very beautiful images. You can see a lot of MAC. You can see the S3 that was implanted surgically. It was implanted transatrially in the MAC position and sewed in place. You can see that the commissure were partially misaligned towards the medial trigon. The neo-LVOT was actually the neo-LVOT was actually close to 0. That's the skirt neo-LVOT. And the skirt neo-LVOT was about 160, and you can see the frame is like essentially touching the septum. So these are the baseline images. You can see very busy, very busy three-chamber view. A lot of turbulence in the LVOT already at baseline. The mean gradient was across the valve was 14. So the plan was to perform a transseptal Batman of the leaflet. I assume that performing a LAMPOON would not have been possible. You cannot do tip to base LAMPOON. You cannot base to tip LAMPOON Transseptal would have been very difficult to traverse the leaflet and then snare the wire and then lacerate and create laceration from base to tip. And plus, I don't think it may have been even like effective because you would have still left some leaflet tissue in the LVOT with a laceration versus Batman. You can potentially completely clear that segment where you have the leaflet. So anyways, this is what I did. So this is the traversal of the anterior mitral, the leaflet that was the most looking the most at the LVOT. So the one that you could see on the CT, on the CT. Transseptal is done with a steerable versacross, and then I put a 6 French IM, and making contact with the 6 French IM catheter. You can see on the TE at the level of the base. Then turnpike astato, burning with the astato, and then traversing. So actually not show here, but the first time I traversed, and then I was trying to send a balloon inside of the leaflet, the balloon will not cross, and like a forward balloon, and then I lost the wire from inside of the leaflet, so I had to recross it. And then what I did, I went back with a balloon and with a guideliner. I did some progressive balloon inflation, and then I balloon tracked the guideliner across the leaflet over the balloon inside of the LV. And then after that, now that I have a guideliner across the leaflet, I put a Notify wire as supracore, so it's not pre-shaped. And then I finally did a leaflet laceration with a 14, and then implanted the valve. I had kept a pigtail retrograde across the LVOT in the LV, just in case. I think it's no, actually in the lungs. I can't remember. But anyways, this is the final result. I closed the ASD because there was bidirectional flow. She has severe TR. This is the final results. And then in terms of gradient, there was no increase in LVOT gradient. Anyways, I'm going to show the tracing, the tracing of the gradients, but essentially there was a reduction in the LVOT gradient after this. The patient did great. The total fluoroscopy time was 67 minutes, and she ended up being discharged on post-operative day 3. And she's asymptomatic as of 9HA class 1.
Awesome, beautiful case. So, how do you choose your point of transversal? Do you, because when you're doing aortics, you go by CT angles. Do you rely heavily on the CT angles, or do you rely on TE to guide you to the point of traversal?
I don't use the CT at all to get the traversal. I just go by T. You want to be in a three chambers view on the T. You want to make sure that your catheter is touching the base of the leaflet. This holds true for everything, for MAC, for rings, and for valves. Sometimes with rings, when the leaflet is very tethered, it's hard to get like your catheter completely perpendicular to the base of the leaflet. So what I do, I use an IM inside of a steerable catheter. So you let me put back the slide.
And you rely that you're in the middle of the leaflet based on the fact that in a three-chamber view you should have you should be at A2 essentially.
Yeah. So first I get into the area where I want on 3D to make sure that I am at A2. And then to make sure that the concept is that you need to make contact with the catheter on the tissue before you traverse.
So when you say you want to make contact with the tissue, you want to see the formation in the mitral valve in the leaflet, or?
You want to see that your catheter is in contact with the leaflet. You want to see this. You want to see this.
Mm-hmm.
You want to see your catheter that is touching the leaflet close to perpendicular. So you're making contact. You don't want your catheter to float too much above the leaflet. What happens in those cases when you try to electrify and traverse, the wire slides over the leaflet and ends up in the LV, not inside of the leaflet. So not across the leaflet. So you want to make sure that you're making contact with the catheter, you're touching it. Once you're making contact, then you advance the microcatheter and the wire, and you electrify and you traverse there. And then after that, you can confirm that you have a wire that goes into the LVOT and then inside of the LV. Usually, it's a combination between fluoroscopy and TE. On TE, I usually for this, and then making sure you see wire in the LVOT, not going through any structure, any dangerous places. And then on fluoroscopy, you will see the wire that loops into the LV and that moves together with the anterior mitral leaflet.
Is there any situation where the wire, instead of going towards the apex, will go preferentially towards the aorta?
Not towards the aorta in my experience, but if you burn so when you burn, you usually want to count like up to 3. You don't want to burn. You don't want to do prolonged burns. Otherwise, as someone is pushing the wire can continue to travel burning and can go through muscle and stuff like that. So usually you wanna use like short burns. You can count up to 3. I usually ask my tech to do 1, 2, 3, and then stop burn, unless I tell you otherwise. That's the safest way to do it, because so you avoid that your wire keeps traveling and inside of structures. It can be that it has happened in this case. I burned inside of the muscle, the wire, and there's was buckling inside of the septum because the leaflet was like right in front of the septum.
Yeah, you had no separation there.
There was no separation. So there, what I did, I pulled back, and then I rewired, and then the wire went back in the LV.
And you're preferring 014 wires over 035. Why is that?
Yeah, I know a lot of people do with 035 wire. I really don't recommend to do with 035 wire because it's in my opinion, is less safe. I know you save a step, but with 014 wire, he is more forgiving. If you're going across structures you don't have to, or if you don't like the position for whatever reason, let's say you're too far away from the base, then you're concerned your modification is not gonna work. You can always pull back and recross. It's not a big deal. This is all truth for both mitral and aortic.
Okay. Well, I know you got a big case coming up, so let me ask you one last question, and then maybe we'll find another time to talk about other things. But
Yeah.
You mentioned you use a 14 millimeter balloon before you put the valve in, right?
Yeah, that's what I usually do.
Okay. So, because on the aortic side, obviously, on the unicorn, during unicorns, there's a big debate whether we should rupture the leaflet before we put a valve in, or whether we should, not do that. In this case, it sounds like you go with a big balloon and you don't have any issues advancing the valve across the leaflet, correct?
Yeah. So it happened to me in both ways. So sometimes the balloon lacerates completely the leaflet towards the free edge, and now you have a laceration and you put the valve. And has happened also in long anterior mitral leaflet for valving rings, where the 14 is not enough. I've done two ways. I've completed laceration with a bigger valvuloplasty balloon, or I've just like went for like intraleaflet implantation of the valve, and I haven't found much difference, to be honest with you. In the aortic position, I am I kind of like apply the same concept as with the mitral. So if for native I prefer basilica. If you have a frame, I think it's fine to do unicorn. I haven't had the issues that has been described by other people by completely lacerating the leaflet with a bigger balloon. I personally haven't. I usually what I do, I go with the Astato. I do a first dilation with a coronary balloon. I switch to an 035 wire. I complete a laceration usually with a 14 or 16, and then I put the valve. I've done single unicorn, double unicorn. I didn't have leaflets embolization or other stuff. So the concept of true intraleaflet implantation sometimes is elusive because you never know if you're gonna. It's very hard to have an exact control if your balloon is gonna just make a hole versus lacerating completely the leaflet. And also, I have heard of like people getting stuck with the valve, not able to go across the leaflet when they were using a smaller balloon.
Yeah.
Right.
Yeah.
So to me, that's worse than actually clearing the leaflet completely with the balloon and then putting the valves.
Yeah, no, I agree with you. And since we had problems in one case, we on the aortic side we go with a 14 millimeter balloon. So very similar to what you're doing.
Yeah, and particularly, and this is particularly true for the fail evolutes. The fail evolutes to me, like unicorn with the big balloon is the way to go. You have leaflets that are sitting like this. Sometimes it's very hard to do basilica in this. You can go with this too crowded inside of the frame with two catheters, snarings, etc. They can get stuck. So I think like they're unicorn. You go with the big balloon, you complete the leaflet, and then you put the valve.
Yeah, no, I totally agree with you. Well, Gennaro, thank you so much for this. I really appreciate it. I know you have a big case coming up, so we'll do this again. Thank you again, and learned a lot. And thank you.
Yeah, thank you for having me, guys.